Hi, good morning, everybody. My name is Dr. James Lehmann, and I'm going to be doing the lecture today. Let me just share my screen. Okay, so today I'm talking about penetrating keratoplasty. I gave a similar lecture a couple of years ago, and it's going to be kind of the same topics, maybe just updated and some improvements from the last one. Here are my disclosures. None are relevant for this talk. And we're going to start with a few poll questions. And Lawrence, who's running this from Orbis in New York, will tally up our answers. So this is for you all, the audience. I have performed penetrating keratoplasty. 1, never. 2, 1 to 20 cases. 3, up to 50 cases. And 4, 51 cases plus. So go ahead and answer that poll, and in about 10 seconds, Lawrence will show us the answers. This helps me to know kind of a little bit where we're level we're at with the audience here. Okay, so never, and so 86% of the audience either never or very beginning. So okay, that's good to know. That's what this lecture is directed for. So which of the following is not a contraindication to a PK? So not a complication. So active OCP, untreated exposure, keratoconus with a scar, or active graft versus host disease. Which of those 4 diagnoses is not a contraindication? So go ahead and put your answer there. Okay, so 67% answered keratoconus with a scar, correct? And then another question here. When performing penetrating keratoplasty, which is true? The donor should be larger than the recipient, or the recipient should be larger than the donor? Which one is true? All right, 83% answered the donor should be larger than the recipient. And then the last question here. If a patient has a corneal scar and a mild cataract, the surgeon should do a PK3, that's a corneal transplant and cataract extraction with IOL implantation. Or the surgeon should just do the PK and then months later come back and do the cataract. Or the patient should take the cataract first, then do the PK. Or the surgeon should perform DMEC. So we'll get an answer here. Go ahead and tally them up for us there. So this one's a little more complex, corneal scar and a mild cataract. And let's see what the totals are. All right, so we'll get into that a little more. So here are our objectives of this lecture. Number 1, to understand the preoperative planning for a PK, and then to learn about the intraoperative steps. Then we're going to learn how to avoid and manage intraoperative complications. So the preoperative part is important because if you do good preoperative planning, you'll have less problems intraoperatively. So just a little bit of background. Penetrating keratoplasty has been done for hundreds of years, but it didn't get really done in earnest until the 50s and 60s, started in New York with Dr. Castroviejo. And this is a graft where they used a double-bladed knife and made a square type transplant. This is from an actual patient that I saw years later. And for a long time, it was just one size fits all. Every patient that had corneal pathology that was bad enough to need a transplant would end up getting a PK. And now we know that's not the case. So here's just a little overview of the different types of corneal transplants. On the upper left is the penetrating keratoplasty, also called a PKP. To the right is the DALK, which is about a 95% thickness, leaving behind Descemet's membrane and a little bit of the posterior stroma. Then there's a DSEC on the lower left, which is an endothelial transplant where you have Descemet's membrane, endothelium, and a little bit of posterior stroma. And then DMEC, which is just the Descemet's membrane and endothelial cells. And then lastly, at the bottom, you have a KPRO, which is a PK with a center of a plastic cylinder so that if the rest of the cornea vascularizes and rejects, the center remains clear. Okay, so in the United States, this is a little trend over the last 20 years of transplants. Basically, 50,000 transplants are done a year. And in 2011 is when more EKs were done than PKs. So now PKs are leveling out around 17,000 a year. Of course, there was a dip last year because of COVID. In the United States, the 2 main reasons to do a PK are keratoconus and a repeat corneal transplant. In India, for example, the indication's different. So that's mostly therapeutic PKs done for ulcers, and then an optical one done for a regraft. That's the number 1 reason for a PK in India. In Colombia, for example, I misspelled that, by the way. Sorry about that. It was spell check. Bullous keratopathy, therapeutic, and corneal dystrophies. That was from 2018. And so here's some examples. So here's a failed graft. You can see a vascularized graft with superficial vessels. Doesn't look like too many deep ones there, but this would be a pretty common indication for a graft here in the United States. Of course, you'd want to figure out why it failed. Did the patient stop coming in? Did they stop using their drops? Is there some uncontrolled inflammation going on that we don't know about? And you'd want to sort all these things out before doing another one. Here's a picture of fungal keratitis, and we still have these too in the U.S. where a patient will have an infiltrate that we just can't treat with drops, that it won't get it under control, and then we end up having to do a therapeutic transplant. So let's talk about some contraindications to corneal transplantation. These are reasons to treat the surface, treat the eye before doing the transplant. Severe keratoconjunctivitis sicca, so severe dry eye, needs to be treated before you do a transplant, because if you don't, they're going to fail. Their surface isn't going to epithelialize. They're going to have epidefects, etc. Stevens-Johnson syndrome, of course, you probably wouldn't be doing a PK in the short term on these patients, but even afterwards, if they have a dry ocular surface or keratinization, it's not a good milieu in which to put in a new cornea. OCP is something we see in older people here in the United States, and these pictures here show some scarring and some blephara. This would be one that you'd have to be quiet, and they'd have to have what we would call a wet eye. I know that sounds kind of simple, but basically they have to be able to make tears. You don't want to have a keratinized surface just like in Stevens-Johnson's, or else they're gonna reject that cornea. It's not gonna thrive. Limbal stem cell deficiency is fairly common. If it's unilateral, you would do a stem cell transplant in that eye first and let that heal up, and then come in and do a PK later. If it's bilateral, then you got some problems. You either have to do a living related donor, or talk about doing a K-Pro if the surface is good enough for that. And then exposure, that would be like ectropion, or if they have lashes coming in or they can't blink, all those things have to be addressed, and at least have a plan for it when you do the PK, so that you don't have the same pathology come back. Some more contraindications: active infection. Unless you're doing it for that reason, if there's an active infection somewhere, you want to treat that first. And HSV, you want to put the patient on Valtrex prophylaxis or acyclovir, depending on your country, around the time of surgery and even afterwards, to prevent recurrence. And you want the eye quiet before you do surgery. This is kind of the one I see the most: uncontrolled glaucoma. And so glaucoma would be a great reason for a graft to fail. And you have to get that fixed, a tube or medicine, before you do the surgery, because if you just do the transplant, then it's going to fail with that high pressure. I'm going to go ahead and open up the question part. Here you go. Okay, I'm going to go back to play. Okay, so I'm already getting a few questions in here. One of them is, when do we have to continue the steroid? We're not going to talk too much about postoperative regimens, but basically a steroid, they're going to need to be on it for life after a corneal transplant, in some form or fashion, once a day, twice a day, every other day, but everybody needs a steroid for life after a corneal transplant. The last contraindications are multiple previous rejections. So that would be if they've had 2 or 3 grafts and they failed. If you do another graft, guess what? It's going to fail. So you have to think that through and decide about the best next step for the patient. And then an inability to care for the PK. So if the patient is, well, demented, or they have developmental delay, or they are not in a social situation in which they can care for the graft, you have to think about this, especially if it's only one eye and if they're better off not having surgery. Okay, so a little bit about donor cornea selection. Here in the U.S., before we do a case, we send a request to the eye bank, and then we receive a tissue detail form like this that goes over all these things like the age of the decedent, the date of death, how long ago it was, how long the body was cooled, what the cell count is, and we even get a picture of specular microscopy down there at the bottom. So things to look at on this form are the age, of course, the cell count, and a picture itself is good to look at and make sure that there's not a lot of pleomorphism or polymegatheism in the endothelial images. I also like to look at the clear zone, because if I'm doing a bigger graft, I want to make sure I'm not going to have any white arcus that comes into the graft. And then, of course, the other things, such as the date of death, you want to use it normally 12 days or sooner. Most countries that I visited, people use the corneas much sooner. We kind of use them a little longer here in the United States. And then the depth of preservation, the standard is about 20 hours that you would want to use the cornea. There's a question here from Mr. Julio de Leon asking about how to treat superficial opacifications near the suture tracts. Okay, I'll get to that when we go through a little bit of post-op. Dr. John Mathen's asking, why not younger than 15 years old? You can. That's a good point. Now, the thing is, so in PK, if you use a cornea that's like 4 years or younger, it's very pliable, it's very soft, and it's a little more difficult to control the tissue in the surgery. Also, you have a higher chance of it getting distended and having higher K values, keratometry afterwards if there's high pressure. Also, you kind of don't know if these patients are maybe they're gonna end up having keratoconus, other type issues. So it's not a hard stop at 15. It's not even a hard stop at 65. It's kind of guidelines there. But I generally don't like using young corneas. For DSEC, I do, but not generally for PK. The hard stop for me would be around maybe 3 to 4 years old, but you can use younger than 15, of course. These are just some guidelines. These are the donor cornea solutions in the US. We mostly use the Optisol, but there's great solutions across the world. And in Europe, for example, they use organ culture. They don't really use the intermediate term storage like we do, and refrigeration. And in terms of serologic testing, all the donors undergo these tests, including COVID. And the main contraindications in the US, this was from a long time ago, but it was basically hepatitis. That was what came back most positive that caused us not to use a donor if there was a positive serology. At the eye bank, they put the corneas in these viewing chambers so you can look at the endothelium, you can look for exposure patterns, any infiltrates, and kind of document that clear zone. So all that information is important to review prior to using the cornea. And then, of course, you have the specular microscopy. And these video here, you can see from the left to the right that, obviously the left is beautiful, nice uniform cells, all the way to the right where there's dropout with gutata, which you would probably not want to use that cornea. And then in preoperative planning, let's talk about that. Okay, so there's different elements to the pre-surgical planning, and this is what's going to help you to not have complications during the surgery. And so that begins with anesthesia. You got to think about the patient's lens status, if it's a failed PK, and then some unique situations we'll get into. So the goal for anesthesia in a PK is you want the eye not to move. You want the patient comfortable. Those are the two things. If the patient's uncomfortable, they're going to squeeze. That's going to cause positive pressure and you're going to have problems. And so in the US, I generally do probably 95% of these under local anesthesia. That's a retrobulbar block. It's sometimes a Van Lint block, which is in the facial nerve right by the eye. And it's with IV sedation by the anesthesiologist. And he's given them Versed, some sort of anxiolytic. I generally shy away from using propofol during the case because patients will wake up and kind of be startled and they'll tend to squeeze. There's a question by Dr. Katab. Can we use donor corneas with prior refractive surgery? Yes, for endothelial surgery, but I would not use a post-LASIK cornea for a PK or a DALC, but I would use one for EK or like DSEC or DMAC. Back to the anesthesia. So again, I generally use local, but there's not a problem using general if you want to use that, okay? Actually, in most countries I visited and done PKs, the cases are done under general anesthetic. So again, you want the patient to be able to cooperate during the procedure. This goes with the patient's age and mental status. So the younger the patient, the more they're going to not be able to stay still. Also, if you're going to need to do other additional intraocular procedures like an open sky cataract surgery or fixating a lens, which I'll show you some videos later, those may be something that makes you want to do under general rather than with a block. And then that risk for supracortical hemorrhage, right? So if the patient's older, I generally would stop blood thinners on all these patients, but general anesthesia technically, in my opinion, would have less risk of supracortical hemorrhage because the patient would be less likely to buck. Bucking means kind of squeezing, or to be uncomfortable and increase that posterior pressure. So possible complications of the retrobulbar block. This goes for any kind of eye surgery. We know that. Globe perforation, intravascular injection, retrobulbar hemorrhage. So you need to have good practice being able to do a good nerve block before doing it for a PK. But generally you can do these cases under PK. Under local anesthetic. Now we'll talk a little bit about lens management. So there's kind of 5 scenarios that I kind of thought about in my mind. There's a mild to moderate cataract. There's a dense to mature cataract. There's a dislocated IOL. There's a poorly fit ACIOL. and there's aphakia. So all of these situations require a little bit different approach. The most common scenario is a mild to moderate cataract. So in this, I recommend leaving the cataract alone and then returning 6 to 9 months after you've done the corneal transplant to do the cataract surgery after you've done some suture management. Okay, so we'll get into that in a sec. But why do I say that? Well, because any kind of residual refractive error that you have after you've removed the majority of stitches and the patient is stable with a healthy graft, you can treat at the time of cataract surgery and make it more equal to the other eye so they don't have high hyperopia or high myopia. And so what I typically do is an interrupted and running pattern, as you can see on the right here. And this is 4 months after after corneal transplant. The sutures are very tight. I use 12 interrupted, 12 running, and I'll bring the patient back at 4 months, and then I'll do topography. And that topography will then show me where the tight sutures are. Those would be the steep axis as seen on the topography. So in this picture, the one on the left, it shows the steep sutures are around 50 degrees. No, it's saying 30 degrees, okay? I've removed those 2 sutures, and then I bring back the patient a month later, excuse me. And then I do the same thing. So now this is 5 months post-op. And then I do topography. And now you can see the steep axis is 75, and you can see a nice line of astigmatism there. So then I would selectively remove the sutures on the tight axis. And so I do that, and then I bring the patient back in a month. So now this is 6 months post-op. And now you can see we have pretty good SIL. It's around average K around 44.5 and about 2 diopters of SIL on this topography. So at this point, I know that they have good corneal shape, and then I can go ahead and do the cataract surgery. So then I would plan the cataract surgery at this point. I would leave the rest of those sutures in for the long term and only remove them if they became vascularized or they broke. So I always get that question in these webinars, like, how do I manage the sutures? What's better? Is it continuous or interrupted? So this was from a lecture last year during COVID. One of the docs in India sent a question of what's the advantages and disadvantages of continuous and interrupted sutures. So the bottom line is, once the sutures are removed, there's no difference. That's from an old study like 20 years ago. But to me, the combination gives me the flexibility to start removing sutures a little bit earlier. Like I can do them in 4 to 6 months instead of having to wait like a year or 9 months with interrupted sutures. Additionally, when you just have interrupted sutures, you really don't want to remove 2 sutures that are next to each other because that creates an area in which it's going to be weaker. You don't have that problem with the continuous suture. So at the time of surgery, when I place the interrupted sutures, I place them tight. When I place the running suture, I leave it kind of loose. And the idea behind that is I want that running suture to stay forever if I can. To me, and I don't know if this is true, but it would give a little more protection if they bump the eye. But it provides me a kind of a framework in which to remove the tighter interrupted sutures early and not have to be so concerned about leaving a weak graft-host interface. So my vote is a combination of continuous and interrupted sutures. The last thing I'll say on this topic is that it looks a lot prettier when you do a continuous suture. So other doctors, when they look at your corneal transplant, they're going to say, wow, that looks nice. I can't do that. I'm going to send my patients to Dr. Natajran in India. Or if they see these interrupted sutures that aren't even and they're different lengths and everything, they're going to be like, man, next time I'm just going to do it myself. So I'm kind of saying that tongue in cheek, kind of in jest, but the bottom line is that there's some practical and some aesthetic reasons to do a combination. Okay, so if you have a dense or mature cataract, this is a case from 2009 in which a patient had a ruptured globe that violated the lens capsule as well. At this point, you can't leave that lens in there. If it's a very dense cataract, you don't want to leave it. So you would do an open sky cataract extraction. In these situations, you can use a variety of lenses. You can use a rigid PMMA lens like the Alcon CZ70BD. You can use a silicone lens. But what you don't want to use is a one-piece acrylic lens, because when you do an open sky cataract surgery, the capsulotomy is not just like a phaco. You can't be sure that you got that lens completely in the bag. So if you put an acrylic lens and any of it's in the sulcus, guess what? You end up having UGG syndrome afterwards. So you can put in a silicone or a PMMA lens, but don't put in a one-piece acrylic lens. And if you're worrying about doing the calculations, use Ks of 45 and 45 and go ahead and take the axial length from the other eye, okay? And that generally tends to work. So this case afterwards looked better. He was able to see well, and I still see this patient. This happened when he was in high school, and now he's like a dad, and I see him, what now, 12 years later. Okay, so a Flaringer ring. So I always get questions about the Flaringer ring, like why do we use the Flaringer ring? It just adds time to the surgery. Well, I think it's very important if the patient is going to be aphakic at any point in the procedure. So what does that mean? That means if you're doing cataract surgery, for some time, you're going to take out the cataract before you put in the IOL. They're going to be aphakic. So if you're doing a cataract surgery, you got to you got to put a Flaringer ring. If the patient's aphakic already, or if they have a dislocated IOL, you're going to need to use one of these rings because they work like a box kite. So this was a question that I got in 2020. What's the advantage? And I thought these two pictures kind of show a good idea. Basically, the eye will deflate once you take out the cataract. Or if you unroof an eye, you take the cornea off and there's no Flaringer ring, it's going to shrink like a little deflated happy face balloon like that. But if you have the Flaringer ring, it's like a box kite. It gives some structure to the eye. It creates depth in the anterior chamber and allows you to put a lens in the sulcus much easier. If you don't have that Flaringer ring, the posterior capsule starts to rise up. There's not really any space between the posterior iris and the posterior capsule. It's very difficult and more dangerous to put in a lens at that time. So anyway, save yourself a headache. Take the time to put in a Flaringer ring. Okay, so here's a dislocated or poorly fitting IOL. What do you do in this scenario? So what's wrong with this picture? Obviously, you got a cornea that's not happy. It's cloudy, and you have a one-piece acrylic lens in the anterior chamber. So that's a no-no. So that's why this cornea is unhappy. So you have to remove that lens. Some people would even say you could remove that lens and see if the patient will recover and get good vision, if the cornea will recompensate and not stay cloudy. But in this situation, if you were going to do a PK, which you could do a DMEC or a DSEC, you would have to remove the IOL for sure. So it's basically an IOL exchange, and to put a new lens in, if there's no capsular support, you either have to suture a lens, and you can use Prolene, or you can use Gore-Tex, or you can do a Yamane technique where you do intrascleral haptic fixation. So I'll show some videos on this later. Most of the patients that have a dislocated or poorly fitting IOL, they have endothelial decompensation, not necessarily like a corneal scar. So in these situations, you're not really doing a PK. There may be a few, okay? And I have some videos, but most of the time, you're gonna end up doing a two-stage procedure in which you fix the lens problem first, and then you come back and fix the endothelial problem. Aphakia, these may just have endothelial problems, or they may have a full thickness scar or something. And it's basically the same situation. You either have to do a combined Yamane, or you have to do a Gore-Tex sutured / Prolene sutured lens. So when do I decide between these? I've kind of migrated to doing the combined Yamane technique. The sutured IOL is totally fine if that's all you got. And here's some pictures of some lenses that you can suture. The CZ70BD by Alcon. Many companies make a similar one. It's PMMA, and it has those little eyelets that you can use to fixate. And then there's that Aqueous lens by Bausch & Lomb that also has those openings in the haptics that allow you to suture the lens. What's the difference between Gore-Tex and Prolene? Well, Gore-Tex may not be available where you are. It's definitely an off-label use of the Gore-Tex. It's designed for suturing heart valves. And the needles aren't right. So you don't use really the needles. You use just the suture. And the Prolene is much more available. Dr. Koram asked, do you not consider an ACIOL for aphakia or IOL exchange if you're going to do a PK? I think that's a possibility. And if you don't have other technologies available, I think that's a fine option. However, I don't think it's the ideal option. It's not easy to put an ACIOL in at the time of cataract surgery, penetrating keratoplasty, and ensure that it's gonna sit nicely. You can do it, and it takes some practice. You should do a PI, and the patient can be fine, but there's definitely going to be a higher chance of inflammation, of corneal decompensation of the donor later because you have an ACIOL right next to it. These eyes are complicated, and there's not just one size fits all right answer. And so I think you have to take it on an individual basis, but I think that's definitely a reasonable option if some of these newer technologies aren't available to you. Pre-surgical planning. We'll move on to failed PKs. So another question I get is, if you have a failed PK, do you repeat the trephination, or do you try to take out the graft that's there without retrephining? I generally like to do repeat trephination because most of the grafts people had that were old or smaller, and they may be decentered. If it's a graft you did and it was recent and you want to put the same size graft in, like let's say that you just did a therapeutic graft and now you have to do a optical graft, you can just dissect it and remove the graft that you put in. But if they've been in there a long time, I vote for retrephining. And then if they do have a failed PK, let's say a patient you've never really seen comes to you and they have a failed PK, and you're trying to decide, do I do a PK or do I do a DMEC or a DSEC? The most important things are to think about what was the best corrected vision prior to the graft failure. Was the patient happy in glasses or in contacts? Because if that's the case, you can do an endothelial keratoplasty rather than a repeat PK. But if they have an ectatic graft, or it's vascularized or scarred, or they never saw well in glasses or contacts, then I would go ahead and go for a penetrating keratoplasty. And so here's a question, here's an example. This was a patient who presents with a failed PK. You can see it's edematous. Right in the middle of that picture is a bulla on the epithelium. And so what would you do in this scenario? They had good previous vision, but they have graft failure with corneal edema, very minimal scarring. So in this situation, I think endothelial keratoplasty would be the best option for that patient. And I kind of do DSEC in these patients more than DMEC. I think it's hard to get the DMEC to stick in these patients. And so I generally do DSEC. And I would do the DSEC in the area of the, smaller than the area of the transplant. So if it's an 8mm transplant, I do like a 775 DSEC. Now here's a different eye. So this is a vascularized scarred graft. Like if you had this patient, you couldn't just offer the patient endothelial keratoplasty because that's not going to help anything. You probably wouldn't even have a good enough view to do it. So here you have to do a repeat PK. You also kind of want to make sure, like in this patient, did they have good limbal stem cells? It kind of doesn't look like it, right? You could do impression cytology and see if there's any goblet cells. Is there any like corneal epithelium there, or is it all conjunctival epithelium? If that's the case, you're going to have to do a stem cell transplant from the other eye and let it heal up before doing a PK. Another option, like if you don't have the other eye to do anything on, a K-Pro may be the best option in this patient. Dr. Alam just sent a question in. It says, in a case of aphakic bullous keratopathy, would you consider sclerofixation Yamane plus EK in the same setting or two-stage? I prefer two-stage because, well, it's just a little easier on the surgeon. When you're doing a sutured IOL, it can be difficult. Yamane can be difficult, and you can have bleeding, you can have vitreous prolapse, all these things that make it a little bit trickier when you're trying to do the endothelial keratoplasty. Plus, I think it's a little more traumatic on the graft to put that in an eye with all the inflammation from the Yamane or sutured IOL. So I have moved to doing two-stage procedures in which I fix the lens problem first, and then I let the patient heal for about a month or a month and a half, and then I'll go do a DSEC in those scenarios. So this is a picture of a K-Pro like we talked about in a patient with a vascularized cornea. That's going to be your best choice. Another question from Dr. Mohammed Adli. He said, who usually performs the retrobulbar block? Is it the anesthesiologist or ophthalmologist? I think it depends on your hospital situation. I operate with an anesthesiologist who does great blocks, so he does them for me. For example, when I visited Jerusalem to St. John's Eye Hospital, the anesthesiologists do the blocks there as well. However, in certain situations, the residents or the surgeons themselves are going to do the blocks. So I think it's whoever's the best at them and whoever's the most comfortable in terms of the relationship with the surgeon. All right, let's get to the fun part. So surgical technique. We're going to talk about these different steps, beginning with recipient eye preparation. So we talked about the Flaringer ring if you're going to do cataract surgery or they're aphakic. When we prepare the eye, we want to measure the corneal diameter. We want to mark the center, and we want to determine the donor size. So my standard is 8.25 into an 8. So the recipient 8.25, excuse me, the donor 8.25, the recipient 8. And I like to mark using an old-fashioned RK marker for the sutures. And so here's a video of the Flaringer ring, okay? And basically you want to oversize it where there's about 2 millimeters between the limbus and the ring. And when you connect it to the eye, you're trying to do episcleral bites. And you want to use a needle, either Vicryl or silk sutures that are, that's a spatula needle, not a cutting needle, because you don't want to penetrate too deeply into the sclera. The passes that you make do not have to be radial. They can be tangential, oblique, like this image, because it doesn't really matter. What you want to do is get it centered the best you can, and you want to do those little bites there. Some eyes are easier to do that than others, but once you've done this, you have good, good structural support. Kind of fast forward here to the end, and you can even, if the eye is kind of rolling down or something like that, you can kind of use a suture, like another suture stay, to kind of move it more centrally in the microscope. Okay, a few more questions here. We got Dr. Adele. Do you do combined procedure for PBK or only the corneal transplantation? Of course, that depends on the situation. Most of the time for PBK, we're just doing endothelial keratoplasty, not necessarily PK. And then Patrick Atta asked, for K-Pro, do you use a new cornea or the patient's cornea? I generally use a new cornea. It doesn't have to be a good one, like meaning it can have poor endothelial cells. It can have haze. It can have a small optical zone. It can be from a 75-year-old, but yeah, I use a new cornea in those scenarios. All right, so we got the Flaringer ring. We know how to do that. And then in terms of measuring, the way I like to do this, so in this video, I kind of go overboard and I measure a lot and I mark a lot, but I start with the horizontal corneal diameter, and then I mark the center of the cornea, and then I do the vertical diameter and I mark the center of the cornea. And that kind of tells me where I'm going to use my little cross when I aim with the Baron trephine, the vacuum trephine. And I mark the center with a Sinskey hook, and this is the geometric center of the cornea. This is not the pupil, okay? And then I put like a 7.5 trephine on there, and I make sure that's centered by rotating the eye around a little bit. And then I mark the epithelium. And then I can use a marking pen. Now, you don't have to do all this. You can just mark the center, but I did this for illustration. This helps you to center the best. And now I'm using the RK marker to mark where I want to put my sutures. And that makes life easier. Okay, so what's the benefit of all these marks? All righty, so I'm going to go back a little here on the video. Now check it out. When you trephine this, I used a smaller trephine than I'm going to use for real trephination. So this helps me use the Baron trephine to mark the center of the cornea. So that's like the crosshair. And then you can look around, and as long as you've incorporated all the dots, you know when you're on that vacuum trephine that you're centered on the cornea. And then these RK marks are really helpful, especially for passing the first 2 sutures. And so the next video is that host corneal trephination. So this is the same case. And then this is what I was talking about. Look here in the middle. I'm using the crosshair for the dot, but then I'm looking to make sure all these dots that I did on the smaller trephination are inside mine. That means I'm not grossly decentered. And then I'm turning. And then some people like to enter the AC. Other people like to stop and then enter the AC with a super sharp. It doesn't really matter. It's whatever you're more comfortable with. I think that if you cut all the way to where you get a little aqueous, you kind of have a more uniform cut, but that also decompresses the eye fast, and it can kind of make people a little more nervous and stuff. So entering in a controlled manner where you have the scissors going the same way every time is fine. So then I entered in a controlled manner. I'm right-handed, and I entered right here. Now I'm putting in a cohesive viscoelastic and then using those curved corneal scleral scissors to find that gap. The main key when you use these scissors, you don't want to forget this, is you can put them in oblique, but you have to rotate them perpendicular to the cornea so that you don't get a shelf on the incision, so that the incision becomes vertical like this. If you end up cutting with the scissors kind of oblique, then you get what we call like a corneal shelf, where the cut is like this instead of like that. Now, that's not the end of the world. It sometimes gives you a little better framework if you're doing it in a very thin cornea, like a pellucid. You kind of want to leave a bigger shelf because then you have more surface area to suture into. but in most cases, it's not necessary. So you saw that I went around to where I was comfortable in this direction, and now I'm coming back with the other scissors, the other direction scissors, back to this way. And with my left hand, I'm kind of retracting back the cornea, and you kind of pull it centrally so that you expose this little gap and make sure that you're in the line that the trephine already cut. And so you want to be able to cut, and then you can go back. And if there are areas that you didn't like that you left a shelf, you can go back with Van Ness scissors and kind of cut that to get a more even graft host interface. So again, start with the good marking. Then you're going to trephinate. Why don't you go as far as you want? Then you enter in a controlled fashion. You place viscoelastic, cohesive, and then you go in and you use this left hand to retract centrally the cornea so that you can get those in the groove there. And then you make slow controlled cuts all the way around with the sutures, with the scissors as perpendicular as you can get them. Okay, now donor prep. Now, obviously you do this before you did what I just showed, because you don't want to be having an open globe and then coming over and doing this. Now, I like to do donor prep under the microscope because it helps me with centration. I hate cutting an off-center PK. It is so frustrating and it looks not pretty. So most places I go, I see the surgeons doing this and they do it on the like Mayo stand without a microscope. But if you can, use the microscope. So I use a little purple marker and I mark the central area here of the barren trephine, and that allowed me to center it better. And then I punch it and I use a lot of force, and then I rotate it around and I use 0.3 sutures, 0.3 forceps to kind of rotate, and that makes sure there's no connection to the graft. And then I put a little bit of Optisol back in this well, and then I cover it up, and then I go do the trephination of the recipient. So obviously you want to prep the donor before the recipient. I should have shown that video first. A little side note, these are called temporary K-pros. These are cases where the cornea surgeon is doing the case alongside a retina surgeon. The retina surgeon doesn't have a view. And so you want to take off the old cornea. These are mostly penetrating trauma or hyphemas or something bad. And so you're going to trephinate the cornea. You're going to suture this temporary K-pro onto the eye, and then they're going to do their retina part, and then you're going to take this part off and you're going to put the new cornea on. You don't want to put a nice new cornea on and then have the retina doc in there with the vitrector, blah, 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 for an hour. So that's what a temporary K-pro is. They make them in different sizes, but you kind of want to do a little bigger than your normal PK when you're doing these. Okay, so another situation. This is open sky cataract surgery. So this is from a case that I staffed in China during an Orbis trip, maybe about 10 years ago. And so we've taken off the cornea. The patient's under general anesthesia, and you can see the cornea, the cataract's pretty dense. So this is the trainee doing the surgery. He or she put some trypan blue, and then the type of capsulotomy that you want to do in this scenario is just a old-fashioned can opener style capsulotomy. You don't have to do a CCC. So you just want to make nice, easy cuts where they're continuous so that you don't have a tag that runs out, and you just go all the way around. So I'll move so the surgeon's doing that. So the capsulotomy in this area has been achieved, and now the surgeon's continuing. And now we're going over here, just slowly, kind of bringing everything to the middle here. You're just trying to do them close enough together so that you don't get a tag that runs out. Once you have it, you kind of verify by freely moving this cap. Now I know it's freely movable and nothing's coming with it, so I know we're pretty good. And so then you remove this cap. And now you're going to use this cystotome to try to elevate the lens. Now this lens wants to come out. Even if they're big, they want to come out. And you don't have to have necessarily such a dilated pupil. So you kind of try to elevate one pole of the lens, and then you use the cystotome to kind of spin it out. And you can see that big old guy. Look at that. Holy moly. Okay, now the cataract's removed, and now not much cortex there. The surgeon here is putting some cohesive viscoelastic to create a potential space between the iris and the capsular area. And then this is a 3-piece silicone lens. You put that first haptic underneath the iris, and then with your second one, you grab the trailing haptic, and then you pronate your arm, you rotate down, tuck that trailing haptic under the iris, and then you let go, And then as long as both haptics are under the iris, you're kind of in good shape. Then you can push down on the optic, you can coat it with viscoelastic, and then move on to the corneal transplant part of things. Now, many questions I get in open sky is, do you have to do cortical removal? Okay. It's not the same. Most of these are mature cataracts, and you didn't really do hydrodissection. So there's not quite the same cortical plane like you have in cataract surgery. So when you remove them, you can kind of see, you can get a Weck cell, you moisten it, and you can touch on the capsule and kind of clear any kind of cortex that's around the central aspect. And you can leave the rest that's in the periphery. You don't have to go in there with INA and get all that stuff, okay? That's where problems happen, because there's not that expanded bag and space where you can put an instrument. It's all compressed like this because of the posterior pressure. So less is more in these scenarios. Dr. Adele asked again, what should be the size of the donor cornea respective to the type of refractive error? I don't think that really plays a picture in it. I would say that you always want to oversize the donor. I like 0.25, and then fix the refractive error with contact lenses afterwards, or cataract surgery if they're older and they have cataracts. Okay, so here's another video of open sky. This is a patient that has posterior synechia. You can see that all that scarring where the scissors are cutting right here, almost a pupillary membrane. And then they've had a previous transplant. You can see some stitches here. And so I'm removing that pupillary membrane, and then we're going to be left with kind of that dense cataract. And so I'm using the cystotome, and I'm just kind of going under there, and I'm going to try to retract the iris here so that I can go and do a can opener style capsulotomy that doesn't leave a tiny little capsulotomy. So I'm just going to go around and do this. Continue. Using the push pull to kind of move the iris out of the way. And you can see I'm just kind of scratching it and bringing them to the middle there. And then same thing in this lower quadrant. And then the key thing is kind of elevating a pole of the lens, freeing it up. And another trick you can do is use a second instrument to push kind of at the limbus, and that gets the pole up a little bit. Once you get a pole up, then it really wants to come out, and you just spin it. And then you just spin that little bad boy out of there. Even big ones like that can come out. They want to leave. They don't want to stay in there. And so get that mean old cataract out of there. And then there's that, using that Weck cell to kind of clean that central part off. It's a soft Weck cell. Don't stick a dry one in there. And you can kind of brush away on the posterior capsule any central cortical material. You can even use water to kind of hydrate it, and that helps to remove it as well. And then once you've done that, there's that water. You can kind of blow it away and hydrate it. It just kind of wants to leave. You can see kind of fluffy edges here of it. And then I got a clear central capsule there. And now it's time to put in the lens. So I'm going to dry off a little bit so I can see the anatomy a little bit better. And then viscoelastic underneath the iris to create that potential space where I can put that leading haptic. And I'm using a PMMA lens in this case, and it's a good example of the difference there. These play very nicely in the eye. The very inert material. So I put that trailing haptic in. They're just a little harder to do if the iris is small, if the pupil's small. So then I get that trailing haptic, I pronate my eye, I push down on the optic, I get it under the iris, and then I release it. And you just want that under, but it's such a big optic, it stays so nicely back there. So there's that. We're at 8:45. Okay, here's a case that I just did earlier this year. This is a situation in which they have a failed graft that's cloudy, and they're aphakic because of trauma. There it is. I narrated it. You can find this on my YouTube page. But basically, this is one of those cases where they're aphakic. So I could suture one in, but I'm going to do the Yamane. So here I'm marking. This is kind of the most critical part. You do 2 millimeters, 2 millimeters, and then 1. And then I'm putting a Flaringer ring that's shaped more like an oval, so I have room to pass those needles. Then I'm going to prepare the cornea. And then like I did in the other one, I put some Optisol and let it sit. I'm doing a paracentesis so I can put an AC maintainer. You want this eye firm as you pass these 30 gauge needles. And then they're attached to a syringe. And now here I'm detaching it from the syringe and just leaving the needle there, okay? And I'm doing the same here, passing it through the sclera and then I'm going to begin the trephination. I've removed the AC maintainer, and now I'm entering in a controlled manner. And you can see how thick and edematous that cornea is. Now we're left here with an open sky aphakic eye. I left a little hinge here, and there's that IOL. And so with one hand, I remove that. I'm starting to move that needle, and then I'm going to use just some tying forceps to dock the haptic into the needle right here. And now I'm doing the same on the other side. These are very pliable haptics. It's called the Zeiss Lucia lens. And now you externalize the haptics at the same time. I'm retracting the needles, and then you use cautery to do a little mushroom at the bulb of the haptic. Same down there. And then you're safe. They're not going to retract back into there. So now you can proceed with the corneal transplant part of it. So I put some viscoelastic. There's the new cornea. And now I'm speeding this up, but I'm using my kind of initial painting there, and I'm going to do my sutures. So there, the 4 cardinal sutures are being placed right now. Once I have the 4 cardinal sutures in, then the next step is I refill the eye, put some viscoelastic in there, and then I go ahead and do my 8 other interrupted ones. And now a running suture, now closing the conge, and then you'll kind of see here at the end what the suture looks. You can see this case again on my web, I'm in my YouTube page. But anyway, you can see at the end of the case there that we got a nice lens. We'll go back right there. You can see a nice lens there. I did a little iris work that I edited out, but basically cornea in place, and you can see kind of under the conch here, there's that little bulb of a haptic. And so patients do real well with this technique. So a couple of questions. Aisha asked, don't we need to irrigate and aspirate cortical material? So that's what I was kind of talking about. It's not as easy as it is during phaco. And so you don't necessarily have to. The main reason you don't have to is because, number one, most of these cataracts are very dense. They're like mature cataracts. So they don't have a lot of cortical material. Number two, you can blow a lot of it out just with BSS. Trying to get a Simcoe or an INA, a Simcoe works better, but oftentimes you end up pulling on the anterior capsule where you were doing the capsulotomy, and it just creates kind of a headache, and it's nerve-wracking. If you can clear the central back of the capsule with a Wexel, or you can, even the Wexel, sometimes the cortical material will stick to it and you can pull it. Those are fine because the cortical material will dissolve on its own. So you can do it. If you're going to do it with the Simcoe, but I've done a lot of these and I find that it's kind of a waste of time and the eye is open. So I don't really like that. Dr. DeLeon asked, for the Yamane procedure, do you do an anterior vitrectomy? So in this eye, for example, the patient had previous vitrectomy. So that's the best scenario, that they had a proper vitrectomy done by a retina doc. But if it's a Yamane, I would do definitely, yeah, you can't be doing that when there's vitreous everywhere. You got to do a vitrectomy. But most of these eyes, they had penetrating trauma, or they had RDs or something, and they had proper vitrectomy. Dr. Almusa asked, why do you not go for a big CCC rather than canopen or capsulorhexis? I have tried both, and it's very tedious to do a CCC in these eyes because you can't put in viscoelastic and flatten the anterior capsule. It's very round because the eye is open, and it has a tendency to go out. Plus the pupil dilation, for whatever reason, when you open up an eye, it kind of comes down a little bit. It's just not the easiest thing. You can do it. You can even phaco it. I've seen doctors use a phaco, but to me, it's overkill and not needed. A CCC, it can be done, and I have done it before. I just find like it's not the most efficient use of my time when the eye is open. Okay, so donor coronary suturing. So this is a video by Dr. Aldave, and it basically shows really nice suturing technique. So if you can remember anything from this talk, I mean, you want to learn how to suture nicely. And so you use those Pollock forceps the first time that have the 2 tines, and then you basically paint by numbers. You look over here is how you grasp the needle, and what you're shooting for is 90% depth. You don't want it too short, and you don't want it too long. With your non-dominant hand, you kind of fixate on the recipient, and when you start pushing that needle, you want to see some arrow-shaped stria occur in the recipient. Right there is that arrow-shaped stria right there, telling you that you're at the right level, and you want to come clear about 1 millimeter anterior to the limbus. And then when you pull out this needle, you want to bring it out in little pieces. You don't want to just pull it out all in one because it distorts the tissue too much. Then, of course, we do the 3-1-1 knot, and you get it fairly tight. Everybody always asks how tight. You want to say moderately tight, and then 3-1-1 surgeon's knot, and you rotate the knot into you lock the knot into the donor. That's very critical to lock the knot so that you don't. That's what happened just right here. He locked that knot. Well, let me see. Right before that. This is locking that knot forward. He's locking the knot forward. You definitely want to do that on all the sutures. Otherwise, they're going to be loosey-goosey. You don't want that. So lock the sutures always towards the center of the cornea, and use those Pollock forceps if you got them for the first pass of the needle. All righty. And then the next, actually the most critical suture is this next one. You want to line it very nice. And he had very good marking, so it helps. But you're going to see that V-shaped distortion of the recipient tissue. That tells you you're in the right plane. You want to come out about 1 millimeter anterior to the limbus. After you've placed the 4 cardinal sutures, you can dry the cornea, and you want to see a nice diamond shape here. And that tells you that you have good equal tension, and it looks real pretty too. Dr. Mathen asked, do you prefer to bury the sutures in the donor or the host? I put them in the donor, less likely to give vascularization and stuff. And then when I remove them, I always pull centrally with them so that the knot doesn't pass through the interface. Okay, so intraoperative complications, I'm going to kind of buzz through this. Basically, we talked about anesthesia. If you need to put the patient to sleep, put the patient to sleep. When you do the Flaringer ring, you want to use a tapered needle or a spatulated needle. You don't want to use a cutting needle because you're going to pass it too deep. How do you avoid improper trephination? You got to be smart, and you have to double check with your assistant or with the nurse that you have the correct trephine sizes. Always cut the donor first, and just verify before you do both that you have the right size. If you've cut it wrong, you don't really have a good fix for that, so don't do it. Materials for trephination. I like to oversize the donor, 0.25. Some people go 0.5. I find that creates too steep a cornea, so 0.25 is what I like. Avoiding misalignment, you want to confirm that diamond shape. You can always remove one of the cardinal sutures and replace it if you need to. And then if you do have vascularization and bleeding, you can use epinephrine drops on the cornea. You can even use like Tocil in the anterior chamber if you need to, thrombin, these kind of things, as long as you remove them. But overall, if they have a lot of vascularization, you need to do a big 360 peritomy and get everything off the cornea. That normally has a good step, but there can be a lot of bleeding. It can be very long. You just have to be patient. And a way not to avoid the iris, don't trephinate the iris. So when you see aqueous, you stop rotating. If there's an ACOL in the anterior chamber that you're trying to remove, sometimes you have to cut it. You can't pull it because it gets cocooned in the iris. And to avoid trauma to the lens, you definitely want to be careful when you trephine. Any sign of aqueous, you need to stop. If you're not going to be doing cataract surgery, you want to do preoperative pilocarpine to protect the lens as much as you can. And during any iris repair, you want to lift the iris before you, so you don't pass through the lens. Capsular rupture can happen with these open sky, and you have to do a vitrectomy at that time. And you can still put a lens in the sulcus, but I would kind of lean more towards that PMMA one because it's a little more rigid as long as you have enough capsular support. So you need to do a vitrectomy, and oftentimes a vitrectomy is easier to do than in phaco because there's not posterior flow of fluid going in, pushing vitreous forward. So it's a little easier to do a vitrectomy. Dr. Mathen asked, regarding oversizing, is there a rule for keratoconus? I do 0.25 for everyone. The only difference I do in keratoconus or pellucid is I'll make a shelf inferiorly so that you have easier suturing time. Again, if you do have a capsular rupture, it's unfortunate, but it happens. You do a vitrectomy and you're able to have a good result still. If you have to put an ACIOL, it's not the end of the world, and you can do that. Supercortal hemorrhages, these are bad. We all know that. They're risk factors. I think the main take home is get their blood pressure under control and have them discontinue any anticoagulation. If I always send these patients for preoperative approval from their cardiologist, especially if they're older, you just can kind of minimize the risks. Also, if you're doing anesthesia, I like to tell the patient, the anesthesiologist, hey, I'm about to take the cornea off, Are they under? So you verify that they're really sedated. You don't want somebody choking on that we call that bucking, choking on the tube, and then they buck, and that's when you get these problems. So we went through the polls again. These are our final questions. So Lawrence, if you could pull the poll up again. Basically, what is not a contraindication? Y'all did pretty good on this the first time. OCP, exposure, keratoconus, graft versus host. All right, Lawrence, go ahead and put up the answer. All right, so we went from 67 to 88. That's correct. Keratoconus with a scar is a great reason to do a transplant. And then we want the donor bigger than the recipient or the recipient bigger than the donor. This should be 100%. We got a couple questions. There's some questions about certification. So y'all can take that up with the Orbis folks. How much corneal neovascularization do you tolerate before going to a K-Pro? So Dr. Messenger, I would say figure out, do they have a corneal epithelium? Because if not, do a stem cell from the other side. So if you have a little bit, I would say like less than 3 to 4 clock hours, I'd be okay with. If it's 360, the odds are that they don't have good stem cells, and it'd be better to do a stem cell transplant and a normal PK before jumping to a K-Pro. And then lastly, Dr. DeLeon, how to treat superficial opacifications. Those are normally immune deposits. They can sometimes be from antibiotic drops. So I really wouldn't be too, I would treat it with more steroid. Okay. So most of the time when it's around the suture, it's from a immune deposit. So I would treat with more steroid and see how that would work. And then we already talked about continuing steroid. Thank you for your talk. Thank you. Dr. Scher, how do you treat corneal NV, laser? All right, that's another topic. It's really hard to fix. I don't have a great answer for that. Steroid is the easiest thing to try. It helps a lot of the time. Lasering doesn't really help. Once you do it, it comes back. There's a new thing about using chemoembolization and mitomycin, but it's kind of an off-label use, and I'm not that comfortable yet with that technology. How do I deal with anterior synechiae? If you're not doing anything to the lens, I leave them alone. But if you got to take the lens out, then I break them using a cyclodialysis spatula. And so, okay, I'm going to sign off, guys. I appreciate your time, and I hope to do this again in the future. Thank you very much.